I'm very privileged tonight to be with Dr. Furaida, one of the first physicians in the United States to work on reducing medical errors and enhancing patient safety, especially in the field of trauma and general surgery. Dr. Furaida, thank you so much for being here. I have one question for you. Tell us about the beginnings of this field, and if you can just shed a little bit of light about your early efforts to improve patient safety and decrease medical errors in the United States, we would really appreciate that.
Well, the quest to improve the patient safety and avoid medical errors is as old as the practice of medicine. Of course, every practitioner was trying to improve, that's no doubt. Now, the problem is medicine is advancing every day, just like everything else in life, and the complexity is increasing. So with complexity and with advances, there is more potential for errors, as well as newer fronts for errors that nobody knew about before.
Right.
In the United States, again, the American Medical Association and different academic centers, including the University of Pittsburgh Medical Center, were at the forefront of this.
Great.
And
that was in the early 2000s or in the 90s, late 90s?
I believe that Dr. Richard Simmons at the University of Pittsburgh Medical Center started working on medical errors exclusively around the year 2000.
Okay.
I think so, or thereabout. And so this may be the beginning of establishing a patient safety fellowship that didn't exist before, of establishing a core group with the main task and job of ensuring patient safety and reviewing everything that happens to any patient at a hospital. So that's the...
And if you can shed a little bit of light on your early research in this field, that would be great. And the paper that is published in your name?
Again, it's in my name and others, Dr. Simmons and Dr. DeVita and others. Well, they were the pioneers. They started what used to be called the Condition C response team. Right now, it's known all over the United States and the world as the Rapid Response Team. And these rapid response teams, our research was identifying the criteria for calling the team. So this team is a team that you call when you can't call, when the criteria to call, for example, a code team is not met. But research has shown that before the code, there is deterioration.
Right.
So we call the rapid response team, and so we were looking at the criteria to call that.
Great.
And the paper that I published looks at quantifying the response and the results of utilizing this team.
Right.
And there were a few papers, and even after I left, of course, the effort continues, and they are the pioneers that
That's great.
carry patients.
Thank you so much.
Thank you.